We can record this.
Yeah.
So I'm doing my smear, we've had the whole conversation.
Okay.
Shut up!
Okay. Alright, I'm going to begin. So today's talk is about renal. What I thought to get you awake is if everyone stands up. Okay. It's not that exciting. Just with a pen, just write over here. If 1 to 5, if 5 is you're super confident, 1 is not very confident, how confident are you about what you're expected to know to the standards you're expected to know for a third year at Renal? You don't want to have to watch each other, but just go around and just tick it, do a tick. So I want to compare it to the start and the end to see if it makes any difference. Basically. Hopefully you'll be a bit more confident by the end of the session. That's the point.
Are we saying that this is how confident
Confident
we
you
know
feel.
the stuff in the curriculum, or that we know it, we actually
So you actually know not what you need to know.
one.
You actually know the curriculum things. Have the knowledge.
I can't follow instructions.
And I'm hoping at the end there'll be some improvement.
So these are 2. How many?
How many?
Okay. Alright, fine, good, great.
So is Kat.
So what kind of teaching do you get in Renal this year? What kind of teaching?
Renal transplant surgery every week.
Renal transplant unit. And
Oh,
they have a
nice.
few teachers about anything other than renal transplants.
It's very
And we'd be
technical.
like, we want to learn about liver disease. They're like, well, no.
Fine. And
I think it's like variable though, because your consultant is like a
Yeah, we have a day of renal disease teaching.
who did you have?
10 lectures,
Oh, wow,
maybe was
okay.
it about that?
We didn't get that.
Dr. Rafiq Gochman? Who was it? Yeah, Dr. Gochman.
Yeah,
he was
it
good.
was great.
So the answer is
So everyone's a variable.
Variable.
Oh, right. Okay, fine. Okay, so this is what I got from your. Okay, this is the feedback from last session first, just to respond to it. So a lot of people basically said that should go through more cases and include everything that was talked about. So I'm going to try to go through a lot of cases and try to go through it in some detail. Yeah? Okay, so this is from your handbook about the stuff that you should have seen and know about. So in terms of emergencies, they say acute electrolyte disturbances, acute renal failure, I think, and then neurological things, and then procedures, catheterizations, cystoscopy, dialysis. Has everyone seen dialysis? Okay, that's good. And then renal transplantations, a lot of you have seen, and general urinalysis. So and then you have pathology, you have aims and objectives in pathology. Does this look familiar? Yeah. So in your pathology course, I think you need to know about glomerulonephritis. How do you guys feel about glomerulonephritis? No. Okay. So what I wanted to do was to talk about basically acute renal failure, so AKI, the causes, the electrolyte abnormalities, and then in AKI I would go through glomerulonephritis because that seems to be the stuff that is a little bit more tricky. But it's just the basics that you need to know and have a good understanding of. Okay? And obviously ask me any questions if you want in between and everything else. So who knows what an AKI is? What does AKI stand for? Okay. And what does it mean? How do we define it?
It's got criteria that define it, isn't it?
Yeah. So the rifle is a way of stratifying it, so that's one way, or AKIN is another way to say how severe your AKI is. So how would you know a patient has AKI?
No, urine output or
Yeah, so reduce urine output is the one thing that you think about. Is the urine output reducing? That would be a sign of acute kidney injury. What else in the blood test? Yeah, so if the creatinine is raised, and you have to compare that to their baseline creatinine. So what would you classify as a baseline creatinine?
120? 120?
So it can be a baseline for an individual can be 120. So creatinine. So you do it within the last year. If they've had a stable creatinine, you want to choose within the last year what their base. That's how you define a baseline. If it's 2 or 3 years ago, then technically you don't really have a baseline because you don't know what's happened intermittently. And what kind of things are affected by creatinine?
muscle mass.
Muscle mass is really important. So obviously a really small lady versus a younger, healthy guy is very important. So the decreased urine volume of less than 0.5 mils per kg per hour for 6 hours is technically what you define as AKI, or an increase in the creatinine from baseline within the last 7 days. Okay, so how do we define AKI, what the cause is, how do we define that?
Pre-renal renal.
Yeah, exactly. So pre-renal, renal, post-renal. So what are the causes of pre-renal? Okay. Hypovolemia, sepsis, renal artery stenosis, yeah.
Hemorrhage.
Hemorrhage, so hypovolemia, yeah.
Hypertension.
Yeah, so hypotension if you're not perfusing your kidneys properly. So definitely things that you're not perfusing, so hypertension, hypovolemia, any sort of shock, or any of the failures which isn't causing it, so if you have liver failure, cardiac failure. You have renal artery stenosis, so what can stenose renal arteries? Yeah, it could be atherosclerotic, it could be an acute embolus. What else?
Drugs.
So calcified drugs don't acutely cause a stenosis.
Is it not ACE or aspirin?
Cancer could, but that's very rare. ACE and what? Sorry.
Is it one of them constricts? Is it ACE that constricts?
Yeah. So ACE will work. So if you have renal artery stenosis and you put someone on an ACE, then their renal function will deteriorate quite significantly, because for any patient, if you put them on an ACE, their glomerular filtration rate will go down because you're decreasing the amount of vasoconstriction of the afferent arteriole. But obviously if you have renal artery stenosis, that will worsen it. So the types of renal artery stenosis, so you have atherosclerotic type, and then what's the other type in younger patients you get? Women, young. Yes, fibromuscular dysplasia, which is basically the muscle is dysplastic and thickened, and that's why you have a stenosis there. Okay, so that's pre-renal renal failure. And then you have post-renal. What causes other post?
Blockage, so stones.
Yeah. So stones,
Mm.
yes. So anything that's blocking the system. So stones, yeah.
BPH.
Yes. Or tumours, or anything that's actually causing an obstruction, basically, to the system, causing backflow. So you can have a hydronephrosis caused by an obstruction, yeah. And then renal. What are the causes of renal? Okay. Yes, tubular interstitial nephritis, good. Tubular interstitial nephritis is one such cause. Yeah, glomerulonephritis, good.
Get the light chain deposition.
Yeah, you can get-
myeloid.
Yes, yep, you can get light chain disease, yep. Any other conditions that you've heard of?
TV.
TB can cause it, yeah.
Tumours.
Tumours.
What's the thing where you get the myoglobin and hemoglobin?
Rhabdomyolysis.
Yes, so that's myoglobin, yeah, yeah.
What was that name?
So rhabdomyolysis will cause renal failure as well. Good. So we'll go through those in a little bit of detail. So the first thing is, why are NSAIDs bad for the kidney?
Because they increase prostaglandin formation, which leads to vasoconstriction of the afferent.
Yeah.
So
No, it stops vasodilation of the afferent and
So yes, so to maintain the filtration pressure, you have to have a good difference between the afferent and the efferent, yeah, to maintain it. And what happens is when you NSAIDs, what are the consequences of putting someone on NSAIDs? So you have renal, worsening of renal function. What are the other side effects?
Ulcers, yeah.
Sorry?
Ulcers.
Ulcers, yeah. And what other thing you have to think of when you start someone on NSAIDs? They're coughing all the time. They have inhalers. Yeah, so if you're asthmatic, that's the other thing you have to think of, bronchoconstriction. So what you have to think of is in these patients, if you're stopping the prostaglandin synthesis, if you, on a normal patient, if you give them an NSAID, that shouldn't really affect their renal function, because the amount that it blocks doesn't have an effect on your glomerular filtration rate. But if you have a pre-existing disease, so if you have CKD, so for whatever reason, if you have chronic kidney disease, and what's the most common cause of chronic kidney disease?
Diabetes?
So diabetes is one of the causes, yes? Hypertension. So renovascular disease is the most common cause. And then what's the other causes of CKD in the UK? Structure, so polycystic. So yeah, so if you have CKD for whatever cause, or if you are volume depleted, so you're an elderly patient who's not eating and drinking for a couple of months, or if you're on an ACE and ARB, so already you have some existing pre-renal failure, then you depend on your prostaglandin synthesis to maintain your GFR. And if you give that patient NSAIDs, then they're not able to compensate for that. Whereas if you gave a young patient NSAIDs, it wouldn't really affect their renal function. Obviously you don't want them to stay on it forever, but that's why they're more dangerous in the elderly, those who are volume depleted, those who have established kidney disease, or if you're on ACE and ARB. Yeah? Okay, so how do we assess patients with pre-renal failure? We need to think of fluid assessment, basically, because the main causes are hypovolemia, relative hypovolemia, shock, sepsis, things like that. So that was the basic parts of fluid assessment. Should we go around?
In, out.
Yeah, in, out, so find out how much is going in, how much is coming out. So you want to find out how much is the intake and how much the urine output, yeah?
Okay, time scale.
Yeah.
Yes, and how much they've been volume depleted.
Yes, yeah. And how would you clinically assess them?
Oops.
Well, let's start from the history actually. How would you, from the history, assess them?
Find out about any vomiting.
Yeah, vomiting, diarrhea, you get lots of fluid loss from there.
Any hemorrhage.
Yeah, bleeding, hemorrhage, yeah. So there's things that you can pick up in the history.
Fever, would you?
Fever could, yeah, can give you a bit of volume depletion. What about clinical examination?
You're happy with the blood.
Hmm?
You're
So
happy
good.
with the blood.
Try.
Okay, so start from the beginning. So start from the hands. What are you looking for in the hands?
Lack of skin.
Yeah, so skin, turgor, how perfused are they? Actually feel the hands. Look at the capillary refill time, and then just move all the way up. So then look in the JVP, look at the neck, listen to the lungs, look in the mucous membranes, feel the abdomen. Can you palpate the bladder?
What are you looking for in the lungs?
Basal.
If it's crackles,
Oh, for
if
increased
it's
fluid.
overloaded.
Okay.
And a lot of patients, particularly some of the renal patients, they peripherally look like their volume deplete, but if you listen to their lungs, it just fluid accumulates in different places.
Mm-hmm.
And then if you do palpate their bladder, then you're thinking that could be a post-renal if you feel there's an obstruction there. Okay, so those are the main things you'll be looking at. And of course you want an input-output chart. So this is an example of an input-output chart. Tell me what you think of it. Have you seen fluid input-output charts on the ward?
It hasn't got any volumes on the oral input.
Yes. So this is an example of a not very good chart. So you do get these on the wards though sometimes. If they say tea or water, you want to quantify how much exactly is going in, and then you want to know how much is coming out. But often people do say vomited plus, and you need to quantify these. So it's quite important to know. And what are we aiming for in a euvolemic patient? So a patient who's not overloaded, not hypovolemic, they look normal. What?
Plus.
So input output, what balance are we looking for?
Bit
That's
more.
9,500 mils. So yes, that's right. So why do we look for that?
Just do that other loss.
Yeah,
That's
exactly.
sweating.
So and obviously if they're hypervolemic, what do we want our fluid balance to be? Not a number, but just
Equal.
so you want it to be negative basically, so however much. And if they're hypovolemic, then you may want it to be positive. So it is useful to look at. Not in all wards are they filled out properly, but it's important to get that down. Yeah. So you have a case of a patient. A nurse calls you to see a patient with reduced urine output over only 20 mils in the last 4 hours, and then they've been given 40 milligrams of IV furosemide, and then they had another 20 mils in the last 4 hours. And then another 40 milligrams of IV furosemide has been given. So you've now come to review the patient. What are your thoughts? What are you thinking when you've heard this, someone's told you on the phone, and this is the information you've got? What are your thoughts? Okay, so stop the furosemide. So the furosemide was only given as stats.
Isn't that quite a lot of freezing might give 80 milligrams
Yeah.
in about 4 hours.
So you want to think, why was the furosemide given? Are we thinking, so why would the furosemide why would it be given? What would you think? So heart rate, okay. So this patient, are they overloaded because they've been given that? What else would you think? What would you want to know or find out?
Obstructed?
Yep, are they obstructed? Yeah, that's really important to think about.
What are their odds? Like,
Yeah.
are they cardiovascular? Like, are they
Yeah,
compromised?
so let's say they're stable, all the odds are stable, 120 over 80. So you're going to go onto the ward, you're talking to the nurse, what can you say to them or find out some information just before you get onto the ward? So yeah, so find out, do they have a catheter in situ? And then find out what their urine output has been before. So we're looking at, is this an acute compromise or has something else happened? How much is the input and what exactly has been going on to cause this? Are they vomiting? Is there nausea? So it gives you an idea of fluid assessment. Then obviously you do a fluid assessment. So some people you'll still find, if someone's urine output is low, they'll give them furosemide to try to increase their urine output. But obviously that's just making them more hypovolemic if they are hypovolemic. So that's not the answer, obviously. So, if you have reduced output, obviously you can have any of the causes of AKI, it could be pre-renal, renal, or post-renal. But if you do then palpate the bladder and you say, okay, I can feel the bladder, and maybe there's 900 mils in the bladder, you do a bladder scan. If that's, would you accept that to be painful or painless? Painful, yes. So if it's painless, what does that tell you?
It's a nerve problem.
Yeah, so you think, okay, has this patient got chronic retention and therefore it's not, the actual stimuli is not causing them pain? And if it is painless, then what might you think of doing? How will that change your thought process, or what would that change?
Would you look for some other cause of the change in their sort of situation? If it's painless and it's been like this, what's happened to me?
Yeah, so what kind of things are you thinking?
Infection.